talking about clinical and physical examination in orthopedics, MRCS. Sorry, not in orthopedics, it's MRCS Part B. So I'll be concentrating in detail. First, we'll talk about the general examination. What are the things? See, here, instead of doing the examination proper, we have to know what are the things that we do before we actually start the examination. That is very important. How do you carry yourself through this particular station is important. And we'll try to understand how to score marks and where actually students lose marks. We have been doing hands-on for a very long time with study MRCS. So we'll try to incorporate the RCS style of examination. What is the requirement from RCS for you to clear this examination part with ease? Most of the people who fail MRCS Part B is where this is the skills part. Skills part where you falter. You may be a great surgeon, you may be really good surgeon, but skills part, your professional empathy, it's the examination. If you get everything perfect, if you get everything, all the examination findings correct, everything correct, and you lack the empathy, you lack the professionalism to examine a patient, then you're going to lose marks and you're not going to clear the station. So we'll try to understand what are the important points that we have to keep in mind before we enter the examination station first. Okay. So I'll be talking about all the examination stations in detail today. How do you go through a station? What are the steps that we need to follow? Everything. So before we begin, we'll try to understand what are things that we have to follow. So what is important when you start with the examination of the any examination for that matter? So this is the basic chart here. So this help you depict what are the important things and how do you score marks. So one thing is a rehearse routine. So what is a rehearse routine? For example, once you enter the station, the first thing that you do is wash your hands. If you don't wash your hands and you directly start with the examination, then you're going to lose marks. So the more the amount of times you rehearse, the better the chances of not making a mistake in the exam. So when you talk about MRCS Part B, it's not about years. Okay, the better the chances of clearing the examination. So professionalism is very important. The way you address the patient, you can ask the patient whether you want to address the patient by the first name or the second name, whichever the patient is comfortable. Hi sir, I'm Dr. Rakshith. I'm the exam candidates today. May I confirm your name and age? If the patient tells I'm Mr. Smith or something, hi Mr. Smith. Can I address you as Mr. Smith? So this professionalism is needed. The way you talk to the patient, and where does the professionalism again take part is whenever the patient is in pain. Exam a knee joint or exam pain, and you're trying to palpate the abdomen or any joint, and the patient is screaming in pain. You just stop there and you tell the patient, if you're in too much of pain, let's stop it here. Let's skip this step. Okay, or you just warn the patient before itself. Now I'm going to do this particular test. If it's causing you any discomfort, please let me know. I'm going to stop. So you have to always take this precaution, and patient comfort always comes first. It's for example, if the patient you're examining a knee case, and here the patient has a osteoarthritis of knee, and the patient is in pain. Okay, here when the patient is in pain, you try avoid doing the movements. Okay, because these are painful, or else do the movements within the painless range of motion. If you're doing overstimulation because you want to complete this particular task, the ROM task, or you want to do a special test like McMurray's test or ACL test, if you're not considering the patient's comfort, then you're going to lose marks. It's not just about completing your particular station, but it's more about patient comfort. Is the patient comfortable when you're examining? So always warn the patient, always ask the patient for permission before you do any test. Confirm the patient is not in pain, then only proceed. Okay. Then eliciting and recognizing signs. So this is where people usually you may be scared. If a general will care about a rule, but not that important. For example, you have a CVS case. For example, if it's a CVS case or anything, if it's a CVS case and you're losing, for example, it's a metallic. For example, consider this as a I'm like hard file when you're trying to examination. Okay, so I've done that. So yeah, so if you miss this minor findings, like if you're missing a murmur, if you're missing any simple things, it's not going to matter. But all this matters is the professionalism. That is very important. Okay, so do not worry about your particular findings. That might vary. So do not worry about that. You can definitely adjust. But maintaining a proper professionalism is very important. So this is the basic, and I'll be talking more about that. Just give me 1 minute. Yeah. So after that, I'll be talking more about the other things like yeah, a structured presentation. Once you're done your presentation, once you're done your examination, you got your findings. So how example, when they talk about summary, you don't keep on summarizing everything. You do not put everything completely into the summary. What are the things that you put in summary is very important. Like for example, a positive finding. What are the positive findings? For example, you examine the abdomen. What are the positive findings that you got? For example, the patient has a tenderness in right iliac fossa. The patient has epigastric tenderness. So you put only the positive findings. Today I have examined a patient named so and so, age so and so, with presenting with complaints of pain abdomen. My positive findings on examination is this, on palpation is this, on special test is this. So this is your positive findings only. You do not put all the negative findings. For example, the patient does not have any significant personal issue, and I think you do not put all those things in a summary. So that's going to just prolong your summary, and you might not get marks by just putting negative findings in the summary. So this is very important, a structured presentation. Next, after you present, you give a summary, then a sensible differential plus next step. So this is all Viva stages. Viva stages where once you give your differential diagnosis, once you give a summary, they'll ask you about your differential diagnosis, followed by management. How do you manage? Okay, so this is the protocol that we actually follow in an examination station. I'll be discussing everything in detail when we examine different steps, different cases. Okay, so this is done. Next, so where do you lose marks? Where do you lose marks? This is, as I told you, when you're hurting the patient. And exposure. The one thing that you have to do, for example, you're examining a spine case, a female case, or a breast case, or a CVS case. So examining all these cases, you need most of the problem with examination is you need exposure. Most of the patient, they might not be comfortable with the exposure, so you have to always ask for a chaperone. You have to always ask for a chaperone. So we'll follow the protocol, ask for a chaperone if the patient wants a chaperone. But today I'll be asking you to expose from your waist above or waist below. So if you want to have a chaperone. If it's a breast examination, obviously we have to have a chaperone. There is no other thing. So you have to always ask for a chaperone. If the patient is okay to continue without a chaperone, you can go ahead with that. Or else we have to always make sure a chaperone present. This is very important, very simple. So always practice hand hygiene. You lose easy marks if you miss hand hygiene. Introduction, there is nothing to say here. You must introduce yourself, then only proceed. Missing very obvious thing. For example, if patient has ascites, if patient has hepatomegaly, if the patient has a sternotomy scar in the midline, you're missing that. If you're missing very obvious sign, you're going to lose mark. Otherwise, so do not worry about your findings. For example, you missed something. For example, you've done a varicose vein examination and you missed tests there, you missed obvious signs there. So do not worry about that. Missing an obvious sign, definitely you might lose marks. If you're very disorganized, if you're mixing up your history, for example, you've finished your history of presenting illness, you've gone to personal history, you've gone to family history, and again you come back and ask a few of HOPA questions, then you're going to lose marks. Silent examination is very dangerous, and this is the highest chance of you failing the exam. So what do you do? You always talk to the patient. You need not talk to the examiner. Always remember, the one thing that we do is we always try and turn towards the examiner, explain to him, no, not required. Examiner is not bothered about how you are examining. He's just assessing you. You're not going to score extra marks just by talking to the examiner. So do not turn to the examiner, do not talk to the examiner. So how do you talk? Talk to the patient. Now I'll be doing this. Now I'll be feeling your tummy. If you have pain, let me know. Now I'll be feeling your leg. If you have pain, let me know. I'll be moving your leg. I'll be pressing on your tummy. I'll be doing this. I'll be doing. Always talk to the patient. This is the main thing that always you miss. Talk to the patient. Explain to him what you're doing. If you're examining a case of shoulder or hip joint, tell the patient what you're doing. You just don't start examination. You just don't start palpation. Without telling the patient that you're going to hear his heart sounds, you take a step and keep it on his chest. He doesn't feel comfortable. Always talk to the patient. Silent examination is a case where you're going to definitely fail. Okay, and differential. Always have differential in mind. It's not always appendicitis. It's not always cholecystitis. Okay, there has to be a differential. I always have a differential. It might be very remote chances that this differential is correct, but please do have a differential. Okay, so this is the basic understanding of an examination station. So once we have understood what you're supposed to do, what are the mistakes that we commit, understanding this, we'll proceed for examination of different systems. So this is the framework. So as we discussed, so I'll be going into detail of what are the frameworks that we have to do. I have almost explained everything here. So this vibe does not have any substitute. Wash your hands, introduce yourself. I enter the station. Oh, see, this is something that we all. What happens is in some of your candidates commonly mistaking is sometimes you might forget to wash your hands. What they do is they actually hide the sanitizer somewhere. They would have kept in a location that they want you to find it. You enter the station, if it's obviously visible there, you'll definitely wash your hands. If it's not visible, what do you tend to forget? So make sure if it's not visible there, you ask the examiner, I want to wash my hands, I need a sanitizer. So sometimes they would have kept it, for example, it's a big room, they would have kept it in one corner. Yeah, it's there. Consider the hands are washed, proceed. So make sure if the hand sanitizer is not visible, you ask the examiner to you have to wash your hands. Okay. Introduction. Hi, I'm Dr. Rakshith. I'm the exam candidates today. Today I've been asked to examine your knee, leg, or something like whatever you're examining today, which will involve me looking at it, feeling it, moving it, and measuring it. If you're doing an abdomen examination, looking at your tummy, I'll be touching your tummy, doing some tests as well. At any point, if you have any kind of a pain or discomfort, please let me know. I'll stop it there. Okay. And before you begin, you can ask the patient, do you have any kind of a pain at all? If the patient says, yeah, doctor, I'm in too much of pain, then you can give the patient, do you want to take any painkillers? You want me to offer you any painkillers? If the patient asks for painkillers, you can give him painkillers. You can just tell the examiner, I want painkillers, so you can proceed. Okay. Permission. So here you introduced yourself, you explained the patient everything, you've taken the consent of the patient. Okay, the patient then says, okay, doctor, I'm okay, I can proceed. Then you explain that regarding the exposure and chaperone. So you've done everything, all the formalities you are done. Then expose, then you go for the actual examination. So this is a proper protocol that you have to follow. Then we go for the inspection. Inspection, one thing that many people miss is inspect from end of the bed. Why is this important? Okay, when you're examining a lower limb case, there can be modified footwear, there can be a walking aid. So always inspect from the edge of the bed before you start your actual examination. Then inspection, local, close inspection, whichever part you're examining. Then this look, feel, move, and measure. This is seen in special test for the joints. This is not for examination of other things. Okay, that is one thing that you have to remember. And palpate, percuss, and auscultate. So this is for the abdomen and other system examination. Functions, different as and when this station comes, I'll tell you know. Then the findings, differentials, and investigations. So this is what I have discussed till now in detail. See, after all this, again, what we do is we once you finish the examination, you turn to the examiner and you start summarizing. You want to complete the you want to score marks, but again, you want to lose marks because you're not thanked the patient. Make sure you thank the patient. Once you thank the patient, wash your hands again. Ask the patient if he needs help dressing up. All this is a formality that you have to finish before you start your exam, differentials or giving you a summary. Before you have to do this, make sure you've done all of this. Then only go for summary. Okay. Please remember that you thank the patient. This is a common mistake. It might sound silly because why am I repeating all these things? It might sound silly, but this is where you people lose marks, and we have seen a lot of things. We have seen in our own practice sessions. Instead of repeatedly we talking about this, many people are missing this. This is something that we have to remember. Okay. So yeah, closing the examination, thank the patient as I told. I complete. Now I finished my examination. Thank you for your cooperation. Now I want to talk to my consultant. I will get back to you. Summarize your positive findings, offer a differential diagnosis and investigations. Throughout, talk to the patient, watch the face for pain, compare both the sides, be systematic. So I have gone through this repeatedly till now. I hope everyone has understood what is the important things instead of doing a direct examination. So I'll not be repeating these things when it comes to each and system examination. This is consider this as default. Okay, I'll be talking about in general examination. I will be talking in particularly focused about the other examinations. Okay, so I'll not be stressing on the pre and post examination protocol anymore because we have discussed that in detail. Okay, now first examination and very important examination is abdomen examination. So remember, it's abdomen, but we call it as tummy. Try to practice that tummy. So we use it for lay terms. Lay terms is very important. So use it as a tummy. Keep on using the word tummy because history taking anything, it's always tummy. Okay. So here, this is very important. You start RFs, How do you talk to the patient? Hi, I'm Dr. So now we'll start your examination. Now I'll request you to get your hands forward with the palm facing downwards. Okay, now we're looking at the nails. We're looking at the nails. Now ask the patient to turn your palm upwards facing the ceiling. Now you're looking at the, so you have to talk, you keep on talking this. Okay, now I'll be looking at your, this is what, how, now I'm just demonstrating how, okay, please get your hands forward with the palm facing downwards. Now I'll be looking at your nails. Okay, please get your hands with the palm facing upwards. Now I'll be looking at your palm. Okay, now if you want to look for any capillary refill, now I'll be just pinching on your thumb, pinching on your tip of your finger. If you have any pain, please let me know. Now I'll be feeling for warmth. Okay, next is now I'll be feeling for your pulse. So everything that I do, I'm talking to the patient. This is how I do the examination. You do not just ask the patient to get it forward and turn it, do it. You have to explain what you're doing. Okay. Now you'll be feeling for your pulse. Okay. Now, can you please get your hands, can you get your wrists upwards? Can you hold it like this? I'm looking for any tremors like this. That you're looking for fine tremors. If you go for go for face. Tell the patient, now I'll be looking at your face. So what I'm looking at his face, first is eyes. Now I'll be looking at your eyes. Can you please roll your eyeballs up? I'll be pulling the eyelid below. Okay. Now we'll be looking for any anemia. Then can you please look down? I'll be pulling eyelids above. So you're looking for any tris. Look for the eyes. Then you look for face. You're looking. Can you? I'll be looking at your mouth. Can you please open your tongue, open your mouth and get your tongue to facing towards the roof. Looking for any central cyanosis. Okay. This is the examination that we do. Then we go into the abdomen examination. Then we go for chest examination. Why chest examination is important in abdomen examination? It can be patient can have a gynecomastia that's related to the problems with the liver. So you start with chest examination. So this is very important. Okay. Then we proceed to how do you also, this is the general examination proper. Then how do you examine? First, we start with the inspection. So how do you look for examination of the tummy? First, you look for the general inspection. Then, what is the thing that you always forget while doing palpation? In per abdomen case, whenever you are palpating the abdomen, you have to make sure where the pain is. If the patient tells, you should ask, I want to feel your tummy now. I just want to know where exactly the pain is. Okay. So wherever the patient tells pain, epigastric region, right iliac fossa, left iliac fossa, you have to palpate that part in the last, not in the beginning. It should palpate in the last. Okay. So, and you have to be very gentle when it comes to that area. There are two types of palpation. One is a superficial palpation, one is a deep palpation. So you have to always warn the patient, I will be touching your tummy. At any point you have any kind of a pain, please let me know, I'll stop. So whenever you come to that painful part, do not palpate that. You can tell the examiner, because the patient has pain in that part of the abdomen, I want to skip that particular step. And palpation also you can skip if the patient has pain. Otherwise, you have to do a palpation and auscultation. Shifting dullness has to be done if you're suspecting ascites. So we have to see what kind of a case that is. Depending on that, our special tests vary. Then you can't do other examinations like hernial orifice examination, rectal examination. So we can tell the examiner, I want to complete this by doing hernial orifice, extranegenital examination, digital rectal examination. Then you go for observation, other investigations that can be told in the viva itself. So this is something that how do you follow an abdomen examination? Then, so one thing is you always look at the patient's face. Okay, we have to look at the patient's face also is very important. Then, see, there are two things. I'll tell you this again. Please do remember this is a very important thing. Why abdomen examination is divided into two types. Okay, one is acute abdomen. We have two abdomen cases. One is simple abdomen examination. It can be severely painful or not so painful. One is a post-op abdomen case. So what is this post-op abdomen case? Here, usually post-op, eighth post-op day, complaints of pain in the tummy, severe pain, then fever, chills. Patient is in HDU. They have pinged you to examine this patient. Here, once you enter, you see a chart. Usually, they put a pulse oximeter. Here, multiple readings are there. In this, you'll see tachycardia, hypertension, temperature is increased. Okay, so here you're suspecting anastomotic leak or any infective pathology. So here, it's not a simple OP case. No, it's not a simple outpatient case. It's not a simple inpatient case. It's in HDU post-operative. You are suspecting anything severe. What do you follow? We follow CRISP protocol. What is CRISP protocol? Care of critically ill surgical patients protocol. So here it follows ABCD protocol. So once you see this kind of a scenario, what you do? You just start with CRISP protocol. You tell the examiner, because this patient is a post-operative case and is not doing well, the reading suggestive of infective pathology, I want to switch to CRISP protocol and follow the CRISP protocol. Okay, if the saturation is low and you're doing an abdomen examination, general examination, then you're going to lose marks. Here, most important concern is the safety. Safety is very important. Safety of the patient is very important. Okay, then only you can proceed. If the patient is suffering from pain and you're just doing your examination for the sake of completion of the station, you're going to definitely lose marks again. So remember, there are two types of station in abdomen examination. This is a crisp station one is, and other is just the examination station. I hope this part is clear. So these are some definitely signs that we can get. Most of the times they won't keep a acute abdomen case because it's very painful and it's very irritating the patient. So most of the times it will be a role player. They might be mimicking all this. So groin scrotum examination is not important because this is not asked usually. So you can skip this part. So this is usually stoma, groin, scrotum. Scrotum, sometimes you can have a scrotum examination like hydrocele. If the case is available, they can have a hydrocele case in your thing. Otherwise, most of the times it's not there. Hernia, chances is there in a groin case, there is hernia. Hernia examination can be there, but it depends on center to center. If they have a hernia case, they would definitely keep this hernia case. So we have hydrocele, we have shit between hydrocele. Here it's embarrassing to the patient. Some patient might not be cooperating. It's similar to breast examination and examination of CVS in a patient, in a female patient. Here also exposure becomes difficult. Here also exposure becomes difficult. Be very gentle with the patient, handle this patient very carefully. Do not irritate the patient. If the patient is not feeling for exposure, do not expose. Okay, tell the examiner that patient cannot expose. So I would want to skip this step and do not want to proceed further. Okay, so this is very important. Okay, then hernia examination. As I told, hernia examination again. One thing that we have to examine the patient in lying down position and standing up position. What are we doing? We have to make sure that this patient is. When you're examining this patient, we have to make sure that the patient has reducible. We have to understand about reducibility. To reduce himself, the femoral triangle, where exactly is the location of the hernia? Where make sure that
Hello, sir, your voice is breaking. I cannot hear you.
I'll explain. So what are things that peripheral arterial examination. Here we'll be talking about the other tests. So one important test here is, see, first is examination from the hand. So as I told you, examination is important from the hand examination. So we have to start from hand examination. Again, we have to talk about the examination in the hand. What are the tests that we do in hand examination is important. So here we have to again look for the pulses. You have to ask the patient to open his hands up. You have to look for capillary refill time. You have to look for the pulse. You have to look for the redness in the hands, and you look for tar staining. So if the patient is taking tobacco, you have to make sure that tar stain is also noted. So here we have to examine all the pulses. When you're looking for pulse, the upper part of the pulse is very important. You have to examine the pulse in the hand, that is the radial pulse, the brachial pulse has to be examined. Then when you examine the lower limb, you have to look for popliteal pulse, dorsalis pedis artery, posterior tibial artery, then the femoral artery. You have to make sure all these pulses are examined. Then only we can make sure. It's not like, for example, the patient has a lower limb, you're suspecting a lower limb peripheral vascular disease. You're not just examining the lower limb here. You have to examine all the arteries in general. You have to make sure everything has been examined. Okay, then abdomen, can sometimes this patient can have an abdominal aortic aneurysm. We have to make sure that we have palpated the tummy of the patient also. Then what is this Burger's test? Burger's test is to understand there's something known as Burger's angle or Burger's test. So what do you do is you ask the patient to lie down. Okay, you lie down and lift the limb up. Okay, lift the limb up. Then we have to wait for everything to drain. Then we have to ask the patient to stand down. So we have to see for reactive hyperemia. So this reactive hyperemia tells us this is a peripheral vascular disease. We have to make sure this we have noted the angle. This is the Burger's angle or Burger's test. At what angle is reactive hyperemia? When the patient will drop down, there is a increased flow. This reactive hyperemia suggests there is a peripheral vascular disease. So to make sure this peripheral vascular disease, this is the one special test that we do in this Burger's examination. So to complete the examination, you have to make sure that the Doppler assessment is important. So many people are confused at whether we have to do a Doppler in the exam. Usually, they can have a handheld Doppler. If they don't have a handheld Doppler, they'll have a small NST machine. If I seen an NST machine while examining in their obscure postings, they can have some kind of a device like that to mimic an handheld Doppler, which you have to demonstrate. How do you examine the handheld Doppler? What is the importance of a handheld Doppler? How do you hold it? For example, say I'll tell you how exactly do it. So this is the femoral just give me one minute. Femoral artery. Okay, femoral artery is like this. So this is the direction of the flow. We have to keep the probe like this, in this direction. Okay, like this. So we have to keep it opposite to direction of the flow. So we have to understand how exactly the flow is. So this is how you hold it. Okay. Then ABPA measurement is also important because we don't have time here. Because we don't have much of a time for ABPA measurement, we might not measure it there, but they'll ask you how do you measure for ankle brachial pressure integral, but you have to mention it at the end that I'll be ending this session by doing ABPA assessment, Brui, full cardiovascular and neuro assessment. No, sorry, cardiovascular is enough. Then Doppler and duplex. So this is the test that we do for peripheral vascular test. Then going for the varicose vein examination, what are the things that we do in a varicose vein examination is yeah, that any varicosities, skin discoloration. We have to look for varicosities. Where is exactly the location of varicosities? Any swellings, any lumps, skin discoloration. If any ulcers are there, if any swelling is there. So all these are noted in the inspection. Then palpation, we have to palpate for the vessel. We have to palpate the vein. Then we have to do special test. What is special test we do is occlusion test or tunicate test. So what is occlusion test or tunicate test? So this is look for saphenofemoral junction incompetence. Ask the patient to lie down, to milk all the veins, you occlude the saphenofemoral junction in hand. Okay, ask the patient to occlude the saphenofemoral junction, or you can occlude the saphenofemoral junction in hand. Then ask the patient to stand up. You look for where is the filling happening. If the filling is happening from the distal end to the proximal end, we know it's a perforator incompetence. If the filling is happening from the proximal end after the SFJ release, the pressure is released. If the filling is coming from the proximal to distal, then we know it's SFJ incompetence. There are two types of incompetence. We are looking for perforator incompetence or SFJ incompetence. So this we have to look at. Then following this, we have to do one more test. It's called the Perthes test. So why do you do Perthes test? Is ask the patient to march on spot. What happens in during the patient if the patient marches on spot is the blood drains from the veins and goes above. If this here we're looking for this deep venous system is intact or not. If the deep venous system is intact, the blood proximally. If the deep venous system is not intact, what will happen? The superficial vessels will dilate. The superficial vessel dilatation tells us the deep vessels are not intact. Deep veins are not intact. To make sure the deep venous system is intact. Examination of varicose veins. So then again, this also can be, so this is Trendelenburg test that I told you that now, and Perthes. These are two tests that we have to know. And handheld Doppler is an important of all the peripheral vascular examination, vein examination, arterial examination, everything is important. So always make sure that you have included Doppler examination, that I will complete this examination by finishing Doppler examination at the end. Okay, so this is about varicose vein examination. Okay. So now I'll be talking about mainly here I'll be talking about two things. One is the neck lump, that is, it can be a thyroid or it can be submandibular gland. Thyroid has been repeatedly asked. Submandibular gland, I think it was asked in the recent past two sessions of exam. Submandibular gland had come. So yeah, I'll be discussing that in detail now. 1 minute. So yeah, first we'll be talking about thyroid gland examination. So it can be like, for example, a female, usually 35 year female who comes to you present with neck lump. neck lump. You have been asked to examine this patient and report your findings. So the first thing that you enter the station, wash your hands, everything. So the whatever we discussed initially that we do, then you start the examination proper with the hand examination. Okay, here we do not go with thyroid gland examination. Again, I'll tell you why. Here we in the what are you looking in the hand? We're looking for any tremors. There can be tremors. We're looking for capillary refill time. Then we're looking for any flushing of the, and then we look for pulse if there is tachycardia. So we have to look for signs of hyperthyroidism in this particular patient. Okay, so this is very important, but we do in hand examination. Then we go for face examination. What are you looking for face? You have to go behind the patient. So very important thing is you have to look at the patient is one is eye movements. Okay, first is we'll start with eye movements. Now, how do you look for eye movements? To ask the patient to follow your hand. Okay, so we have to look like go in a following H. Why is this above and below is important is here we are looking for one is ophthalmoplegia, that is protrusion, and second thing that we're looking is lid lag. So if the patient has a lid lag, we have to make sure this movements, eye movements are done. He has to follow your hand. Okay. So we look for lid lag and we have understood the movements of the eye are important. Okay. Then when we start examining the neck proper or thyroid gland proper, we start with the inspection. So how do you start with the inspection is now you explain to the patient. Now I'll just try to demonstrate this scene. Okay. Talk to the patient. Now I'll be taking a look at your neck, which will involve me looking at it and do feeling the lump in your neck, and I'll be doing some special tests, and I'll be hearing for sounds around your neck as well. Is that okay with you? Are you in any pain? No. Okay, we can start. Let's start with the inspection. I'll be taking a look at your lump. Can you please lift your chin up? You're looking at the lump. What? Make sure that you need not tell the size, location, everything. You can just there's a lump in the neck. You can note it down. What is the size, everything. That all you can put at the end in the summary itself. Need not tell to the examiner at that point. Now I'll be inspecting for the lump from the anterior side, looking for the lump. Second thing is we have to look for swallowing. If the patient is when the patient is swallowing, so that also you should give a glass of water. Please hold it in your mouth. Now swallow. We have to look for movements on deglutition. That is the second thing that we look for. The next thing is once you've done the inspection and palpation. Next we go for the palpation. So how do you palpate? So go start behind the patient. You don't start in standing behind you, and now you'll be feeling for your neck. Okay. At any point you have any pain, please let me know. But then you go start palpating. You have to palpate for the surface of the thyroid gland. Is it regular? Is it not regular? If any problem, if any abnormal variations are there on the surface of the thyroid gland, then again you ask the patient to swallow. And the one more thing that I must is protrusion of the tongue. Ask the patient to please protrude their tongue. Okay. So now we have done the inspection, we have done the palpation. So then next is we have to do of percussion. What is the importance of percussion in thyroid gland? We have to percuss. Now you have to explain to the patient that I'll be tapping on your chest. So what are you tapping on his chest is you're looking for retrosternal extension. So this is a very important step you always miss in a thyroid gland examination. So retrosternal extension of the thyroid gland has to be done. This next for any bruit. So I'll be please it might cause a bit discomfort to you. Please do manage. Okay. Then you have to just auscultate. You look for any bruits. Okay. After this, your examination is not yet done. So what are these things? Other thing that you have to do is proximal myopathy. So how do you examine proximal myopathy? Is now can you please stand up from your chair without using the support of your hand? Okay. So without using the support of his hand, he has to stand up. We're looking for proximal myopathy. Then you look for the legs. What are you looking at the legs? You're looking for any peripheral myxedema. So these are everything contribute or constitutes the examination of a thyroid gland. It's not just examination of thyroid gland. Hope everyone has understood this. At the end, again, thank the patient. Then you can go for your summary. So many people make a mistake when they are doing an examination is take history. You're not supposed to talk to the patient regarding his history, like how did the swelling start, does she or he have any constitutional symptoms? Not required. No one is asking you about that. STEM would clearly state, examine the patient and provide your opinion. No history taking is required. So do not take history. Do not just confirm by identity and proceed. Okay. Do not keep on asking about the history. You're going to waste time. You're not going to gain any marks. In fact, you're going to lose marks there. Okay, so this is one thing. Then tracheal position is also important. Where is the position of the trachea? Percussion of retrosternal extent. So this is all we have discussed. Movement, movements on trunk protrusion, thyroid gland. So we'll have differential diagnosis here, assess the thyroid status. Okay, so these are the things that we do in thyroid examination. Okay. Eye signs are very important. So we always miss the eye signs. So we always make sure that we added the eye signs as well in the end. Okay. So how do you describe a lump is important? So size, shape, surface, edge, and consistency. So when you're talking about if it's actual patient, most of the times thyroid is very common. So you can have a actual patient. So it always describe it in a proper way. What is the site of the swelling, size of the swelling, shape of the swelling, surface, edges, and consistency. So we have to make sure everything is super spoken here. Because why consistency is important, patient can have a bony swelling if you're examining limbs. So we have to make sure the consistency is also spoken of, what exactly swelling is arising from. So when you're summarizing any case of a swelling, this is one thing that you have to comment upon. One thing that you have to remember in submandibular gland examination when compared to a thyroid gland examination, what are the special things that we do in a submandibular gland examination is, one is oral examination. We have to make sure oral exam is to ask the patient to open the mouth and inspect inside for the duct. Okay, then is bimanual examination. This is not required. So there's a test where we put one finger in the face, no, sorry, mouth and one outside. So this is not required. Whichever test, for example, a corneal irritation, cotton test, whichever test that's actually causing discomfort to the patient, this test is not to be done. Okay, they have to strictly nature and don't do that. So avoid doing that. Along with that, we have to make sure we examine for the lingual nerve also when you're examining submandibular gland. So eye signs. So as we examine, we always start from the hand. We start from tachycardia, warm peripheries, weight loss, proximal motor hyperreflexia, lid lag, lid retraction, exophthalmos or proptosis, ophthalmoplegia. So this is a test that we already spoke about. So I've spoken about everything that's there in the slide. Okay. So usually cervical lymph node is not a part of MRCS exam. Till now, they have not asked any questions about cervical lymph node examination. Usually what we do is, it is a part of submandibular examination. It's a part of thyroid gland examination where if you, for example, when you're palpating, you have to make sure that you included a lymph node examination in don't uh, you don't actually do it, but you have to do cervical lymph node examination is not required for MRCS point of view. Okay. So we always think breast examination is something that usually does not come because it is not patient will not be cooperative, but this is a very common station, especially if you are giving exam in India. This station usually comes. Even AV fistula has been asked and breast examination have been asked multiple times, not once or twice. Initially, we used to avoid this because we thought it was never common, but there's a lot of common things that's come out right now. They're getting cases of breast. It depends on the patient that you're getting. Depends on the role. If they're cooperative, they might expose, or else they won't be exposing. They might keep a mannequin there. They'll ask you to demonstrate breast examination on that mannequin. So it depends on the examiner that they set up. So it depends on a lot of factors when it comes to a breast examination, hernia examination, hydrocele examination. Depends on a lot of things. Depends on that particular patient if it's cooperative or not. Okay. So one thing that when it comes to breast examination is inspection. We have to see the breast tile, the location of the breast, what is the different position of the arms. So arms relaxed, arms raised, on the hips are leaning forward. So this is all the positions that we examine the breast in. So why do we do this? Sometimes what happens, there can be underlying extension to the underlying pectoralis muscle. So we will look if there is a relation to that or not. That also then asymmetry, dimpling, nipple discharge. So everything, usually they keep a case of lump or nipple discharge in the exam. This is very common. When you see any findings in the skin changes, any changes in the nipple, you have to make sure that is mentioned with POD orange, dimpling, or nipple changes. Make sure you palpate all the four quarters plus the tail. What we do is, when you can start with circular motion or from the nipple outside, but most of the times what we do is we tend to forget this tail. So make sure that you examine the tail of the tail of the breast and nipple. So these two things have to be asked because you ask the patient to squeeze the nipple herself, so we can understand whether this patient has any discharge from the nipple. If you have to make sure that you ask the patient herself to do it. Usually, some stations they say usually they keep a male patient with gynecomastia to prevent this embarrassment for a female. But we have not seen till now. They have kept stations for breast examination, but we have seen females there, but we have not seen a male with a gynecomastia. So most probably, if you get a breast station, it's going to be a female with it can be a nipple discharge or a small lump anywhere. So this is something that we have to make sure. At the end, we have to examine for the lymph node. So lymph node, whenever you're doing a neck examination, thyroid, submandibular gland, breast examination, anything around the neck region or axillary region, we have to make sure lymph node examination is one of the aspect of this examination to complete the examination. Do not make that as a primary examination, okay? Don't do that. Chaperone, as I told you initially itself, so it's a non-negotiable part when you're examining personal things like breast or hernia or hydrocele. So that is one thing. So this is the in detail examination of skin dimpling, nipple retraction, or purity orange and fixed hard irregular lump. So this is all something it's pointing towards malignancy. But do not worry, malignancy as such, they don't keep all these complicated cases. So it will be a very simple and straightforward case. So let's stick to that. Okay. So next, moving on to the hip examination proper. So hip, spine, knee. So these are some of the examinations that come in orthopedics. So we'll try to discuss in detail about these different examinations. Okay. So once we have done all the basic introduction part, everything, then I'll give you a scenario here. For example, patient's right hip is affected. How do you start it? You always start orthopedic examination in gait. Gait is very important. How do you explain this? Can you away me and orthotalgy gait, a short limb gait, the limb is shortened or tendon lumbar gait? So I'll be talking about tendon lumbar gait or tendon lumbar sign. So that is something that we always tend to get confused by. So I'll tell you why. For example, this is the right hip, this is the left hip. Okay. Consider this as a right hip and left hip. So this is the hip joint. Okay, this is the hip joint here and here. So this is the pelvis. So this pelvis and this hip is related. Okay. So when you're standing on this right limb, right? So if you're standing here, what happens is this muscle between the hip joint and the pelvis. For example, it could be gluteus medius. Okay, this is a whole fulcrum here, fulcrum and lever mechanism, head of the hip, neck, and the gluteus medius. So whenever you're standing on the right limb, what will happen to the gluteus medius? It will contract. When it contracts, what will happen to this pelvis? It will dip down and this pelvis will go up. This is normal because my whole of the lever and fulcrum mechanism is acting here. My gluteus medius is contracting. Okay, so this will contract because this gluteus medius contracts and all of this system is intact. This pelvis will come down, this pelvis will go up. Okay, so this is a normal phenomenon. Well, now what's happening here? If my gluteus medius is gone, if my liver and fulcrum, for example, there's a dislocation, there's a fracture neck of femur, or something here is broken, this whole system is gone then. So when this patient is standing on my right leg, if this feature is not acting, this hip won't go down. In turn, it will come down. So the pathology is here, but the opposite hip is demonstrating that sign. This is a Trendelenburg sign. Where do you observe it from? It's observed from the posterior side. You have to stand behind the patient, not in front of the patient. Okay, when the patient is walking, this is a Trendelenburg gait. If the patient is standing on the right limb and the left side it falls down, then here only we can understand this patient has a Trendelenburg gait. Okay, well, how do you differentiate between Trendelenburg gait and a short limb gait? When for example, my right limb is shortened, what's going to happen? My right-sided shoulder will droop. My right-sided pelvis will droop. Okay, ipsilateral drooping will be there in short limb gait. In Trendelenburg gait, the opposite side will droop. So this is about Trendelenburg gait or antalgic gait. What is antalgic gait? Antalgic gait is a painful gait. My right hip, for example, there's arthritis in my right hip secondary to avascular necrosis or tuberculosis, anything. Okay, it can be anything. Consider if there's a avascular anything in my right leg. So what will happen is whenever I'm walking, there are two phases in a stance gait cycle. One is stance phase and a swing phase. Whenever I put weight on that particular limb, it's painful. So what will I do? I decrease putting weight on that particular. So decreased stance phase is called antalgic gait. So these are some of the gaits that we see if you encounter a case. If this case comes, it has come in past two sessions continuously. If this comes, then definitely there will be a simple and straightforward case. It can be virginal case, not actor or role player. So once you're done with the gate, then we go for inspection proper. So what do you do inspection is proper is attitude and alignment. So what is attitude and alignment? So we have to know normal alignment. For example, if you look at elbow joint, there's valgus. If you look at the knee joints, there's slight varus. So where is the valgus? Where is the varus? If you, for example, the patient is lying down, what happens to patella? It faces upwards and outwards. If there's a problem, your foot, if you lie down, your foot also goes outwards like this. If there's a problem in the hip joint, what's going to happen? Sometimes your foot can be straight like this, or it can be interrotated. So there's a difference in attitude and alignment. You might notice this kind of some kind of shortening, or there's some rotations in the limb. For example, one limb is straight, one limb is outer rotated like this. Okay. So here we know there's a deformity in the left limb. So we have to understand to look for this comparative of attitude and alignment between the both the limbs. Both the attitude and alignment limbs of both the limbs has to be symmetrical. If there's variation, then we know there's a problem in that particular limb. Okay. So attitude and alignment is done, then we go for inspection. So every joint examination has to be inspected anterior, from the anterior side, from the posterior side, and from the lateral side on medial side. Okay. Hip joint examination is similar. What are we looking for? Surgery examination, orthopedic examination, it's all the same. We're looking for any scars, any sinuses, any swellings, any pulsations, any discharge sinuses, or any skin discoloration that we have to look for. So on the lateral side also similar thing, on the posterior side also similar thing. So once you have examined this, you have done the inspection, you're looking for any abnormal pulsation, any for example, there is a dislocation, anti-dislocation. There is the abnormal prominence you can see in the hip joint also. That also we should make sure we note it down. Okay, we're done with the inspection. So always remember the how do you see, how do you examine a joint is look, feel, move, measure. Okay, there we inspection, palpation, percussion, and auscultation. We don't have percussion and auscultation. It's movements and measurements, then followed by special test. Okay, so once we are done with the local examination, then we go for feel. That is the palpation. What are the things we palpate? So I'll generalize that for everything. So when we next discuss the knee joint, you can understand what you're supposed to palpate. Now, what are we palpating? For example, if you're palpating a tummy, we know what are the regions that you have to palpate. If you're palpating a joint, what are the things that you can't just palpate a joint, right? But palpate things around the joint. What are the things that you can palpate around a joint in a hip joint? The first thing, the superior is the anterior superior iliac spine. Okay. Then the joint line, anterior joint line, posterior joint line. Then the lateral is a GT. So first we have to do something is which is easily palpable, like anterior superior iliac spine or GT can easily palpable. Why are we doing a joint line examination or joint line is joint line tenderness? For example, as arthritis, this patient can have tenderness of the joint line, anterior and posterior joint line tenderness with that. So this is a part of examination. So we have to palpate the joint line. We have to palpate for the bony prominences. If we're looking at the elbow joint, what are the bony prominences of elbow joint? It can be medial, lateral epicondyle, okay, radial head. So these are the bony prominences. If we're palpating the shoulder joint, what are the bony prominences? Anteriorly shoulder, clavicle, coracoid process, acromion. So these are the bony prominences, GT here. So these are the bony prominences. Every bony prominence around that joint has to be palpated. Okay. First is look, next is feel, that is the inspection, next is the palpation, next is the movements. So movements, you can't ask the patient himself to do it. Sometimes he'll do it, sometimes he'll not do it. For example, you have pain. You have pain in your knee joint, you're not going to flex it. Okay, you tell the patient to flex it. If he has pain, he won't flex it. Doctor, only this much I can do. I can't do more because it's causing me pain. So here we have to understand how much is the exact movement, right? So we have to do two kinds of movements. One is the active movement, one is the passive movement. So how do you explain the movement is important. We have documented everything, but you're not able to explain that in the end, then you're going to lose marks. So how do you explain whether this movement was active or passive? Did you do it or the patient himself did it or herself did it? So how do you explain active or passive? Then range of motion was, for example, I'm flexing the hip joint. If the hip joint goes from 0 to 120 degrees, this is normal. Consider it as normal, 120 to 140 degrees. If the patient has pain, okay, here it's already the hip is in flexion of 10 degrees. It's going up to 90 degrees. After this, you're not able to flex the hip. So how do you explain? Active movement or passive movement, whichever you have done. Passive movement of this patient was from 10 degrees of flexion to 90 degrees of flexion. Above this or below this, it's painful and I'm not able to do it. Okay. So is this movement painful or not painful? Is it terminal? Sometimes what happens when you start flexing from 60 degrees to 90 degrees, there can be pain. It's called terminally painful. Is it terminally painful or it's painful throughout the range of motion? Okay. So active movement or passive movement from how many degrees to how many 0 degrees to 90 degrees, 20 degrees to 90 degrees. Okay. Is it painful or not? If it's painful, it's terminally painful or painful. Important thing is crepitus. What is crepitus? Whenever you do, you keep the joint. Whenever the articular cartilage is intact, it's very intact. It will be nice, right? It will be smooth. So whenever you try to flex, there won't be crepitus. Why? Smooth on smooth will cause crepitus. Whenever there's erosion of articular cartilage, it will cause crepitus. So crepitus itself points us towards osteoarthritis or arthritis. So this is how we explain a range of motion. This is in general for all the orthopedic exam. This is what we are supposed to do. Then we have to do some other test or a special test. So one test that we already discussed is a Trendelenburg test. The one test that we have to discuss is a Thomas test or fixed flexion test. What is this Thomas test? Thomas test is very important. Okay. I'll go into the basics of Thomas test. I'll try to explain why this Thomas test is important and then we'll proceed further. Sorry, I missed measurement. Yeah. So look, feel, move, and measure, right? So what are the measures that we do? Is true length and apparent length. So here, true length and apparent length. So what is the true length? We measure actual true length. You start from anterior superior iliac spine, you go up to medial malleolus. This is a true length. You start from a fixed bony prominence proximally to the spine or proximally to the pelvis. That is, it can be Ziffy sternum. Don't take umbilicus because umbilicus can displace here and there. Ziffy sternum does not. Ziffy sternum to medial malleolus. This is the apparent length. The apparent length is a length where we include compensation. What is a compensation is if the patient has a shortening of a limb, what the pelvis do is pelvis tries to compensate, the spine tries to compensate. So we take this compensation in the apparent length. So we have to take a proximal bony prominence and go to distal. Here it's just the length of the limb. We do not take compensations into account. Okay, so this is one measurement, length of the limb. The second measurement is girth of the limb. If the limb has not been used for a very longer time, then this patient can have wasting. Okay, we have to look for wasting. One is girth around the thigh joint, one is girth around the leg. So these are the two things that we have to look for. Wasting, if there is any wasting or no wasting. So this is about the measurements. Then now we'll go for the special test. Special test, the first test is what is called Thomas test. Okay, for example, see, I give example. So my left leg is shortened. Okay, my left leg is shortened. For example, the shortening is 5 centimeters. So how do you compensate this? So whenever you're trying to walk, whenever the leg is shortened, it's difficult to walk. You're swaying like this, right? So how do you try to compensate? The first thing that you do is you put the foot into equinus, right? Up to 2.5, 2 centimeter, you can compensate with slight equinus or foot rise or shoe modification. You can compensate, not much. For example, the shortening is 5 centimeters, 6 centimeters, then it becomes difficult for the limb to compensate. You put it to equinus, no centimeter. But if you're valid shortening, so who will compensate for this? There has to be something compensatory mechanism proximally also, no? Because what will happen in spine? Because it's all interdependent. What will happen in spine? The spine will also compensate. The patient can have a scoliosis. The patient can have exaggerated lumbar lordosis. So these are a compensation mechanism for the problem in the hip joint. Okay. So now, for example, I want to do a surgery. I want to identify how much is the compensation. Okay. I have to remove this compensation. I have to understand how much is the exact shortening of the limb. Okay. What are the compensation that is there? Everything I have to take it out. So how do I take out this compensation? This compensation is for fixed flexion deformity. The first common deformity is flexion deformity in the hip joint. Okay. So how do you take out this deformity? So I have to reduce this flexion deformity. So what will I do is take a rough bed. There should be no smooth bed. It has to be rough. Okay. Rough means what do you say? It's hard. It's not. There's no bedding. It's hard. So ask the patient to lie down. Once the patient lies down, what happens in normal scenario is lumbar spine will be flat with the bed. Here, you can't pass hand beneath the back of the patient. What will happen in this fixed flexion deformity is there will be exaggerated lumbar lordosis like this. Here, once you look down, you can actually see the light from the opposite side. So this is a sign of a compensation. So how do you take out this compensation? Now we know there's a problem here. Now, for example, my left leg was affected, right? So what will I do is I take the right leg, I'll fold it above and ask the patient to hold it on his chest here. So till when you flex it to a certain point that this exaggerated lumbar lordosis comes down and the spine is on the table and you'll not be able to pass the hand. Okay. When you do this, so the problem is in the left leg, but you flex the right leg. Okay. Then on the left leg, what will happen? Here, this leg will go like this above. So this angle between the thigh and the bed is called the fixed flexion deformity angle. So here, by this we know the compensation. So it is 30 degrees, sometimes 3 centimeter, 20 degrees, 2 centimeter. So we know there what was the shortening was that, and we know exactly we reveal the whatever the compensation or we remove those compensations. So we know exactly what exactly the problem in the hip joint, how much is the shortening in the hip joint. We know the details of all this. Okay, so this is the Thomas test. These are the Trendelenburg test and Thomas test is some test that we have to compulsorily do. The other tests are not that important, so not required. Remember these two tests for your hip joint examination. Okay, so this is in detail about the hip joint examination. So once you're done everything, so you can just finish that by saying thank you and wind up. Okay, so very important, very, very important knee examination. The two orthopedic examination that actually come in the exam, every time there may be one station of these things. So one is a knee examination, one is a spine examination. That's the favorite, very commonly available, so they'll keep it. Okay, so we'll be talking about in detail about knee examination. Okay, so knee examination, when you do a knee examination, there are multiple things. Okay, so it can be very simple is OA knee, and it can be ligament injury, like ACL, most commonly. These are two very common meniscus and all. It's very difficult to assess. Also, it's painful. Also, they won't keep it. If they keep it, also, it's very difficult to identify. It's meniscus. Most of the people can confuse it with because we don't take history here. Most of people can confuse it with the osteoarthritis or any tenderness. So it's difficult to identify. So we'll discuss that also. But these are two things that are very common. But OA is highly common. Okay, as I told, our inspection, our examination proper starts with exposure. Once the exposure is done, start with gait. Okay, so the patient walks around 5 steps away from you, 5 steps towards you. Then you start with attitude and alignment. You look for what happens in osteoarthritis, primary osteoarthritis is the patient will have exaggerated varus. So this you can see classic varus deformity is there. Any rotational component is there. For example, the foot is rotated outwards, inwards, it's going interiorly. So whatever deformities that you notice, attitude and alignment that you have to tell. Okay. Next is inspection proper. What are we inspecting proper? Again, a joint examination has to be inspected from the front, from the side, from the back. From the front, you're looking for any swelling. What happens in any arthritis or anything? There can be swelling or suprapatellar effusion can be there. Any fullness can be there. You'll notice this on an inspection. Next inspection from the front, from the side, and from the back. What is important in a back examination in osteoarthritis is Baker's cyst. This is very, very, very common. This most of the times there can be swelling in the popliteal fossa posterior. That's called a Baker's cyst. So depending on the age, usually 60 years, 70 years, this osteoarthritis is the case. So there can be chances that it can be a Baker's cyst. Okay, inspection is done. So from the front, from the side, and from the back. Then we go for palpation. Be very careful when it comes to cases like osteoarthritis because it's severely painful. And you start palpation, you put a lot of pressure on the joint, it's going to cause a lot of pain. Then the patient is wincing in pain, you're going to lose marks. Be very tender, be very careful. Explain to the patient what you're doing, look whether he's comfortable or not, if he's wincing in pain. These are all very basic things that you're supposed to do. Okay. Next is palpation. Palpation, you start from front. One of the things that you palpate from the front is patella. As I told you, we palpate for bony prominences. Patella, proximal tibia. So we'll draw it here for better understanding. The proximal tibia, this is the distal femur, this is the patella. You palpate for proximal tibia here and here, then you palpate from distal femur, then you palpate for patella, then you palpate for joint line. This is joint line. You palpate the tibia here, go proximal, this is a flare. Once this flare ends, there is a dip. So this is a joint line, medial and lateral joint line. You palpate for medial side, you palpate for pes bursitis, okay, or the goose foot. This from the medial side. On the lateral side, again, on the medial and lateral side, you palpate here for the bony prominence. On the posterior side, you look in the popliteal fossa for any tenderness. So this is about palpation. So we're looking for any problem in the palpation here. We look for any local use of temperature and tenderness. That's very important. And the swelling is there. So one more thing that we see in books that they commonly give is patellar tap test. So always remember, one test for one sign is more than enough. For example, if you're talking about knee effusion, you do a patellar tap. There are multiple other tests, sweep test. That is for other things where there is limited effusion. So what is a patellar tap test? So whenever doing this, you see a suprapatellar fullness is a knee joint here, like this. Knee joint is there. This is a patella. Patella usually what rests on the ear like this. Okay. If there's a effusion, what happens to patella? It's floating here. So once you tap on the patella, you have to hold it like this. Three fingers like this. These four fingers like this. You tap on the surface of patella. If there is patella fullness, this will go. It'll hit and it'll come back. There is a patellar tap test positive. What is the inference of patellar tap test? There is effusion in the knee joint. As simple as that. One test is enough. Okay. Then we have palpated. Then we go for movements. As I told you, the movements are again active and passive both. You go for 0 to 90 degrees, whatever the active the patient. Then when you try to move it, always tell the patient, now I'll be moving your limb from this position. I'll be holding your limb. I'll try to move it. If it's causing you any pain, let me know. So what is active movement? What degree to what degree? Is it painful? When is the pain? If you're doing a passive movement, when is the pain? Is it as well crepitus? Very important. Crepitus is easily felt in knee joint. So make sure if it's a 60-year-old patient or 70-year-old patient will definitely have a crepitus. Keep your one hand on the knee joint and try to fold it and extend it. As simple as that. Make sure that you've done this. Then measurements. You look for the true length from anterior superior to medial malleus. Then you measure for the waist length. Then you can proceed. Okay. So this is for osteoarthritis. You do the same examination in ACL also. Same inspection, palpation, movements, and measurements. No other changes are there. But when it comes to special tests, there's few special tests we have to know. See, remember, ACL is very easy to understand. A Lachman's is an anti-rotatus. Lachman's is preferable because Lachman's is done in 30 degrees of flexion. You can do it in 30 degrees of flexion. You draw the tibia over the femur. So then we have anterior rotatus positive. Okay. If it's a PCL, posterior rotatus positive. Okay. Or posterior saxon. What is a posterior saxon is when you flex the knee joint like this, usually they are like this. If there's a PCL is gone, what will happen is the femur, this is the tibia. It will sag posteriorly. So this is a very important sign for PCL injury. Okay. Then other test is valgus and varus. Medial and lateral is there. If it's medial, this is broken. Then the opposite side, it goes opposite side. It is a valgus testis. If medial MCL is gone, the valgus testis is positive. If the LCL is gone, the varus testis is positive. Okay, it's opposite. If see, one thing is whenever you do osteoarthritis examination, when you always tend to do all these tests, it's severely painful. It's not easy for the patient of 60-year-old to cooperate. Just skip the test. Please do not do the test if the patient is pain. Remember, this is general for all the examination. Then McMorris test or Apples grinding test is a test for meniscus injury. It's very, very painful. Even if the patient has a meniscus tear, you try to hold the limb, rotate, flex, extend. It's going to cause severe pain, severe discomfort to the patient. If the patient is in pain, try to avoid doing it. At any point, keep looking at the face of the patient while doing all this examination. If the patient tells, yeah, now I have pain, stop it then and tell the examiner there's pain, so I want to skip it. Do not force your examination on the patient. Then after that, he can tell I want to complete the examination by doing a distal neurovascular examination, and I want to get few investigations that he can do in the summary itself. Okay. Then see shoulder, elbow, and hand. Elbow has not yet come, but hand and shoulder. Hand is very common. Hand examination is very common. You have seen hand examination. So I'll go into depths of examination of a hand. What are the things that comes in hand examination, and what should we understand when it comes to hand? So this is where most of the people actually go wrong. Most of the times, the hand examination is carpal tunnel syndrome, CTS or carpal tunnel syndrome. Okay. So here, usually female patient, 30-year-old female who presents with the tingling and numbness, you are asked to examine the hand and do something in the hand examination. You can ask the patient to sit, give a proper pillow, and keep your hand over the pillow itself. Okay, you can keep this hand over the pillow and examine. Then you start with hand examination proper. So as all orthopedic examination procedure, you start with inspection. You look for any scars, any wasting. So what do you look? You look for here, any scar is there. You look for any TNR eminence scar, wasting is there. For example, a carpal tunnel syndrome, chronic carpal tunnel syndrome is going to be wasting. Or any skin changes are there, any, for example, how do you say, dryness of the skin, any dryness of the skin, because there is loss of hair, there is shiny skin, you have to see that. And you look for nails also. How are the nails looking? Are the nails clear, or are there any cracks in the nails? You have to make sure, you have to make sure you have understood there are no, all these inspective findings are confirmed on inspection. Then you go for palpation. So what are things that we palpate in hand? So it's not only carpal tunnel syndrome. If you're talking about carpal tunnel syndrome, we have fixed number of tests that we're supposed to do. If it's a case of rheumatoid hand is very common in India, especially. You can get a case of rheumatoid hand. If it's that there, so our examination differs a bit there. So what is the problem with rheumatoid hand is there may be multiple deformities in the hand. There can be a sphenic deformity, there may be botanic deformity. So we have to make sure we identify all the swellings. If there are any here, what do you say, any nodules here, any swellings here, we have to make sure that we noted this down. In carpal tunnel syndrome, it's about wasting. In rheumatoid hand, it's about deformities and swellings around the joints. So now in palpation, what are we doing? Localize of temperature, then you palpate for the joints. How do you palpate like this? So metacarpophalangeal joints or metacarpophalangeal joints and interphalangeal joint. Tell the patient, now you'll be feeling for your hand. I'll be feeling different joints of your hand at any point of time. If you have any kind of a pain, please let me know. I'll stop it. Okay. So that is about the palpation. Then what are you palpating here? You're looking for any thickening of the nerve, any scars is there. Okay, so this also you can do palpation here. Then tinel sign also you can do. What is the tinel sign is? We tap it here. When we tap on the median nerve, if the patient has tingling or numbness in these three fingers, we can consider this as positive tinel sign. Whenever you tap, if he has numbness or tingling, this is tinel sign positive. Any scars are there, you have to palpate for the scars. If the patient has undergone any surgeries, you have to look for scar tenderness also. Okay, so these are the things that we have to make sure that we know. Inspection is done. Next is palpation is done. Next is special test. So when you are doing special looks, feel, movements. What are the movements? What are the movements in the wrist joint? First is fingers. So extension, flexion. You can ask the patient for movements of the fingers. So here we can all see movement of all the fingers here. Okay, this is active movement. Next is wrist movements. Dorsiflexion, plantar flexion. Then we can do some supination and pronation also. So we can do all this test for wrist joint examination. Movements. What are the measurements? Nothing. You can take a forearm girth as well if you want. Otherwise, nothing much in measurements. But where does a hand examination actually play a role is what we do is examination for the median opponent's policies. As the patient, please get your thumb. Okay. Yeah. So one thing is hand. Okay. One thing is hand examination. So the problem here is this, examination of the median nerve. So now we are exposed like this. So what are the things that we examine is the thenar eminence. We examine the loaf muscles. Now is lumbricals and opponent's pollicis. So how do you do opponent's pollicis examination? Get your thumb and opposite with the fingers. So this is for the opponent's pollicis. Then what is the pen test? You do a pen test like this, no? Hold the pen like this in front of the thumb like this. You have to palpate for. This is a pen test. This is a test for abductor pollicis. Then lumbricals. So how do you examine for the lumbricals? So we examine for the median is pad and dab, it's palmar interosseous and dorsal interosseous. What is the function of lumbricals? Lumbricals cause flexion at the metacarpophalangeal joint and extension of the interphalangeal joint. This is the function. What will happen if the lumbricals are gone? It will go into clawing. So this is called a partial clawing. Okay. So if this is not test are positive, then we can confirm this patient has a median nerve injury. This is very common. Median nerve injury is very common. Okay. So once we have done this, there's few special tests that we have to know in median nerve examination. What is the special test in median nerve examination? Carpal tunnel examination. What is the special test in there's Phalen's test or Durkan's test? What is Durkan's test is? See, you hold it here. This is the median nerve injury location. You have to palpate for the ring finger. Come here, hold it here, press it here, and hold it for few seconds like this. Okay, you hold it here. So that time the patient has tingling or numbness, then it's Duckman sign positive. Or Tinel sign also can be done. You do this. Then what is Phelan's test? You hold it like this for a few seconds. If this patient has any tingling or numbness in these three fingers, then it's positive again. Okay, so this is about special test and hand examination. Very important when you do a hand examination. Okay, now we'll go for the next part of the examination, that is the shoulder examination. So what are the common things that we get in a shoulder? Either it can be a rotator cuff tear, or it can be a adhesive capsulitis, or frozen shoulder. Okay, rotator cuff tear, adhesive capsulitis, or frozen shoulder. So now we'll be talking about general examination as we discussed, or the say inspection. Inspect from the front, from the side, and from the back. If you're looking for any wasting, is that any abnormal prominences are there? If it's a neglected dislocation, if it's an axonal nerve injury, you have to look for bulk of the deltoid. If there's any wasting, if there's an abnormal prominences, any scars, any sinuses. Then palpation. You start from the medial side. You go from the medial side, palpate the clavicles, go laterally. Palpate for the coracoid, then go laterally. Then palpate for the acromion, posteriorly go laterally. Here you palpate for GT. Okay, you palpate all these bony prominences around the shoulder joint, and anteriorly you palpate here, okay, on the anterior joint line of the shoulder joint. So by this way, we have palpated all the bony prominences around the shoulder joint. So inspection is done, palpation is done. What are the movements? There are multiple movements in the shoulder joint, active and passive again. So you go for flexion, abduction, external rotation, abduction, extension. How do you do external rotation? You can just ask the hand to go outwards like this. You can hold it like this and go it outwards. Internal rotation and external rotation. So we do flexion, extension, abduction, cross body adduction, then internal rotation, external rotation. So these are some of the tests that we do for movements. The special test is one thing that is very important in shoulder examination. We'll come to that. So there's one special test for frozen shoulder. If both active movements and passive movements, when both of them are restricted, it's called a adhesive capsulitis or frozen shoulder. Okay. Then what is the next test that we do? Is do for rotator cuff examination. What are the rotator cuff muscles? Supraspinatus, infraspinatus, teres minor, and subscapularis. Okay. Supraspinatus. What is the test for supraspinatus? It's called an empty can test or a full can test. You ask the patient to get his hands forward. You apply some resistance here at this point of the hand. Ask the patient to elevate like this. Okay. If the patient has pain in an empty can test, so then it's positive. Empty can test is the supraspinatus. Infraspinatus and teres minor, both of them act as external rotators. So ask the patient to external rotate the limb and give resistance on the lateral side. If the patient has pain while doing an external rotation, then it's called external rotation lag sign. That is important for infraspinatus and teres minor. What is the test for subscapularis? There is two tests. Either it's a belly press test or a Berger's lift off test. Belly press or Berger's lift off. What do you do in the Berger's lift off? You ask the patient to take like this. This part of the hand has to go to his back. Okay. Then, for example, consider this as my back. This is my hand. Okay. Now, what will I do is ask the patient to lift the hand from the back. So this part of the patient's hand opposes his back like this. This is called the Berger's lift off test. So these are the tests for supraspinatus, infraspinatus, teres minus scapularis. So two diagnosis, two tests. So this is what you have to know about shoulder joint. Not very commonly asked, but knowing basics about everything is important. So orthopedic examination in general as a whole proceeds from look, feel, move, and measure. Then ankle and foot examination is very rarely they are asked about ankle and foot examination. Some things that we have to know about ankle and foot examination is this one: Thompson's or Achilles rupture. So what is this Achilles rupture? What is the Thompson's test is? Whenever ask the patient to lie prone and flex his knee like this. Okay, consider this is the knee joint, this is the hip joint. Your patient is prone. Okay, here the foot. What will happen? The foot will be like this. Okay, if the tendo Achilles is intact, this foot will go into plantar flexion. If the tendo Achilles is torn, this foot will go into dorsiflexion. Okay. So now, when you squeeze the tendo Achilles, what's going to happen? If the tendo Achilles is intact, it will go into plantar flexion. Okay, it will go into plantar flexion. If the tendo Achilles is torn, it will remain in dorsiflexion. It does not go into plantar flexion. So this is the diagnosis for Simmons test or tendo Achilles rupture. Okay. So tendo Achilles rupture can come, or usually it's rare. I'll cover the foot drop. Foot drop case I'll cover in spine examination itself. So it's very important. Foot drop and spine examination is something that we commonly encounter in MRCS exam. So we'll go into detail how spine is very important. So very, very important. Not I can't just emphasize on how detail you should know in spine examination. So I'll be covering detail for the next 10-15 minutes on how to do a spine examination and neurological examination. In this particular examination, I'll be covering about foot drop. Okay. Yeah. Okay. Most of the time, the spine examination is somewhere around L4, L5. A backache radiating to lower limb. More, it can be a role play or it can be real examination. Yeah. So first, I'll go with spine examination. Same procedures. Same. After the general introduction, everything. And eat. So one thing no in spine examination. It's not the simple gait that we do in. The gait that we do is 5 steps. Then is the equinus. That is on the heels. These are three kinds of walk we do. Why do we do this? If the high stepping gait, the weakness flexion, this patient can have a difficult. In spine examination, so one is the tiptoe gait, one is the heel gait. Okay, so whenever the patient has weakness of plantar flexion, the patient has difficulty in walking with a tiptoe gait. Anisha, this is the maximum I can do. Wi-Fi is this much only. Can't do much. Change the Wi-Fi connection. Yeah. So this is the inspection. So once we are talking about the gait, so here patient is walking on a tiptoe gait. Okay. 1, 2, 1, 3. So tiptoe gait, when the patient has difficulty in plantar flexion, it's difficult to walk. Okay. And patient has dorsiflexion weakness. What's the problem with dorsiflexion is whenever the patient has dorsiflexion weakness, then the patient has difficulty in walking over the heels. Okay, so this is the two things. One is a normal gait, one is a plantar flexion gait, one is a dorsiflexion gait. These are three kinds of gait that we have to do in neurological examination, whether it's a spine examination or a foot examination. Okay, so now we start with spine examination proper. So here 1, 2, 1, 3. So first is the inspection. What do you do in an inspection is, first is, you look for the spine, attitudinal alignment. If the spine is normal, or if the spine is kyphotic, or the spine is scoliotic, like this. Look for the attitudinal alignment. Then you have to look for any abnormal scars, any sinuses, any swellings, anything like this. Okay, you can look for this. And next is for the palpation. So what we look in palpation is, we have to palpate the spine as whole. But here, because the MRCS, it's very concise. So we have to stick to the point. We have to not go into details of everything. So for example, here in the stem says examine for the lower back. This patient has lower back ache. So we have to concentrate on lower back only. So how do you examine? Then you have palpated the posterior prominence of, or look for any tenderness and next movements. So what are the things that we do in movements? So what are the movements that we do in spine is, one is forward bending, one is backward bending, and one is side bending. So ask the patient to stand, ask the patient to bend forward. Can you please bend forward to try to touch the toes? Okay, when you try to touch the toes, so that is called forward bending. Next is extension, spine extension. You go backward and you try to go backward. This is for spine extension. You try to bend laterally towards the knee joint, that is spine lateral flexion. On the opposite side, it's spine lateral forward flexion, extension, and lateral flexion on this side. The flexions on either side, so we have to do. Then we have to go for rotation. So how do you go for rotation? Rotation is important. So how do you do rotation is, because the problem with spinal rotation is the pelvis also helps in rotation. So we ask the patient to sit on a table. Then we ask the patient to rotate, turn on one side, both the sides. Then we look for rotations. Okay. So this is about the movements. Then what are the measurements that we do? So one special test that we do here is, what are the special tests that we do in spine? One is SLRT. So what is straight leg raising test? So what is a straight leg raising test is something to assess for sciatica. So this is a test that we need to assess for sciatica. So what is with sciatica is, so as the patient to lie supine, the patient has to lie supine, then we lift the leg. Okay, you hold the leg like this, you lift the leg. When you try to lift the leg, if the patient has pain, for example, whenever you're lying supine and you try to lift your leg, this is a passive movement. You have to do it, or the patient should do it. So before you do it, you have to warn the patient, I'm be lifting your leg. If you have any pain, please let me know. As the patient lies supine, lift his leg. Usually, you can lift the leg up to 90 degrees, 110 degrees, everything. But if the patient has pain at 60 degrees of flexion, what's going to happen? If the patient has pain at 60 degrees of flexion, then we know that this is sciatic stretch test or SLRT positive. What does SLRT positive mean? Because when you're trying to lift the leg passively, you're basically stretching the nerve root. So whenever you stretch the nerve root, it's going to cause pain. So we know that the straight leg raising test is positive. So this is an inference for any disc bulge at L4, L5 level, L3, L4 level. So this is about the leg raising special test that we do for spine. So one more test is called the Schober's test. What is Schober's test is, you ask the patient to stand, you take a marking, posterior superior iliac spine. Okay, here you mark for 5 centimeter, here 10 centimeter. Ask the patient to bend forward, and we have to look for the differential bending. If the patient has something like ankylosing spondylitis or anything, so this does not increase. Usually it's more than 10 or 10 centimeters, something like that. Usually it will be 5 centimeters, something like that. If the decreased range of motion in the lower spine, then we can consider it as ankylosing spondylitis or painful. Okay, so this is about ankylosing spondylitis. Then we'll go for next is the very important examination in a spine is neurological examination. What is neurological examination? So this, for this examination on foot drop, spine neurological examination and foot drop examination is almost same. Okay. Then now first we'll start with what is a neurological examination. Basically, now we examine the spine in general. Now we have to examine the neurology of the nerve roots. Okay. We can start with a tone. So how do you examine tone? There are multiple tests. We'll do one test. That's called a log roll test. You ask the patient to lie supine and you just roll his foot. If the tone is high, what happens? He'll not be able to roll it in an easy way. If it's hypertonia, he'll not be able to roll it in an easy way. If it's hypotonia, he can easily roll it. So we have to make sure the tone is normal or not. This is very important. Okay, hypertonia or hypotonia. Once the tone is done. Next is power. What is power? So here, see, when you're examining a lower back, don't start with the hip. Okay, because see, we know this, they are talking basically about L4, L5, L3, L4, that level. So how do you examine the foot examination? You start with the foot, dorsiflex the EHL or great toe. Okay, so that way we're covering L4 or L5 level. So here we can get a positive finding. It can be at the level of L4 or L5, you can get a positive finding. So that way we can document in the final summary also. So this becomes very important thing in the final summary. So foot and EHL. Next is you can go for knee examination. Then power of the knee examination can be done. So we have to try to find a positive finding for a summary. If you start examining from the hip joint, then it might be difficult for you to even reach the foot. Okay, so that's why start from the foot. So one is tone, next is power, next is reflexes. So what do you do in reflexes? Here you can examine ankle reflex, okay, knee reflex, ankle reflex. So what is the important thing that we have to expose properly? You have to warn the patient. So I'll be tapping on your knee, I'll be tapping on your ankle. Do you have any kind of a pain? I'll let you know. So please let me know, I won't tap. Always warn the patient, then only proceed further. Okay, first is the tone, next is the reflexes, next is the power, next is the sensory. So how do you examine the sensory part is very important. We have to know the basic understanding of how do you examine sensory. So here what we'll be using is a wisp of cotton. Okay, we can use a wisp of cotton, but we have to understand how does the patient feel. So you can touch it here, in here. Then you can tell this is how the wisp of cotton feels. Then you can start. Now close your eyes. Now you'll be feeling at a point. For example, you're looking for L5 dermatome, both the legs. Okay. Now On the right side is the normal side. You palpate on the L5, you touch on the L5. As the patient, can you feel? Yes. Now, same L5 on the opposite leg. As the patient, can you feel? Yes. Now, what is the next question you ask? Whether both the things were same or not. Whether both the things were same or not. If it's decreased one side, increased one side, paresthesia was there, any problems like that, we have to note down. So first is you have to understand, you have to make the patient understand what exactly are you doing. Okay, second thing is because you know exactly patient has to understand how does he feel it. Does he feel it normal or not normal? Then you have to do this test with the patient eyes closed. Okay. So these are the tests that we do for sensory examination. Next, we can go for proprioception. Ask the patient for to keep the eyes closed and position of the great toe. Okay, position of the great toe is important. You have to just hold it on the sides. Okay, you should not hold it like this. You have to hold it on the sides. You can do a dorsiflexion and plantar flexion as the patient where exactly the great toe position is to understand the proprioception. Next is coordination. You can ask the patient to get the right heel on the left knee and slide it down to understand the coordination. So this is how we proceed in a neurological examination in the spine or a varicose vein. For a varicose vein, there is a station like this. What does the station say? Patient has undergone a varicose vein surgery. Post varicose vein surgery, patient has a foot drop and has difficulty in walking. So this difficulty in walking post foot drop is where the patient has difficulty in walking post foot drop. So that time we can look for a scar in the proximal aspect of the tibia that has led to common peroneal nerve injury. Okay. So these are the things that we have to keep in mind while doing the examination. The problem with spine examination is you have to do all this examination in 6 minutes. So it's not possible at all. So do not worry in the exam if you're not able to complete this particular station. So do not worry at all. You can just proceed with how much you'll be able to complete. But make sure at the end of the station you thank the patient and complete it, summarize everything. Try to do as much as possible. If you're not able to do it, do not worry, it happens. Almost everyone, they'll not be able to complete this station. So that is an understandable thing. If you get a foot drop, it's easy. So these are some of the red flags that we see. So age less than 20, more than 55, a thoracic pain or night pain, night sweats. So these are the pointing towards infection. It can be tuberculosis these are the things that are pointing towards malignancy, fever, immunosuppression, weight loss, so everything. So like this. And if there is a cauda equina syndrome, patient will have a bowel and bladder involvement. Bowel and bladder involvement in a spine case is very serious. So this thing we have to remember. Okay. Next we'll go with the cranial nerve examination. Okay, going on to the cranial nerve examination, basically you run through all the cranial nerve examination that we have to know for the exam point of view. Okay, we'll start with the first cranial nerve, usually not required. They are clearly mentioned it not required. Optic nerve is very important. So we'll start with the acuity. Okay, visual acuity, near vision and far vision. Color vision is not needed. Near vision is also not needed usually. Only the far vision is needed. Okay, then you look for the reflexes. You look for eye reflexes. One is the direct torch reflex that we can see in the eyes. Then we look for the pupillary reaction post these reflexes. So very important, we look for the reactions in the eyes for the examination. Then we look for accommodation reflex. We ask the patient to look when you're sitting in front of the patient has to take a point behind your head. Okay. Then you start to get a hand in front of the patient. Then you have to look for a visual accommodation. The next thing is the visual field examination. How do you do visual field examination? Is you can ask the patient to close, then you get a finger above from there, then you get the finger from all the four directions. So whenever you see this, you have to see the same eye. Okay, you have to see the same eye. Whenever you see the finger, patient has to see the finger at the same time. So that is visual field examination. So visual acuity, then the light reflex, then the visual field examination. So these are three very important signs. Accommodation reflex. So these are the four very important signs that we do for optic nerve examination. Next is eye movements. So eye movements we can do for elastics. So how do you do eye movements is you ask the patient to follow your hand like this. Okay, you make a H, go up, go below, follow like this and follow above and go and go. Then the patient has to look above. And here we are looking for movements of the eyes. If anything, any problem are there in the eye movements. Then we'll go for examination of trigeminal. So we look for facial sensations. So facial sensation examination here again when you're examining for facial sensations. So whenever you're doing for facial sensation examination, your patient has to close the eyes. As I told you, patient has to know how he feels. So whenever you're touching here in the face, you have to ask for the patient whether he's able to feel that. Okay, then only you can proceed further whether he's able to feel it or not. When you're doing a facial nerve examination, you have to for the motor examination, like lifting of the eyebrows, closing the eyes, and you try to open it. Okay, the patient is able to open it or not open it. Then puff out the cheeks. Ask the patient to puff out the cheeks, and you try to press it, and patient should not let it clench the teeth, like look for platysma. So these are some of the things. Then what are things you are not supposed to do? One is corneal examination, where you're putting cotton in the cotton in the eye is not required. That is out of the question. The second thing that you're not supposed to do is taste examination and smell. So this is something that is not needed because it's going to cause some irritability to the patient. The next thing that is the Renes test and the Weber's test for hearing. So when you're doing vestibular cochlear examination in particular, the one thing that we always miss, we always do is vestibular and cochlear together. So here we do cochlear examination, we do Renes test and Weber's test, but we forget about vestibular examination. So what are the things that we do in vestibular examination is march on spot. Okay, the first thing is about the balance, whether the patient is able to balance is normal or not. So we make sure the vestibular part of the cochlear examination is also done. Then the hearing examination is done. Then the important thing is this fundoscopy and the otoscopy. Here they would have the instruments, but you need not give the inference. Okay, so you have to tell them how to hold it. For example, you are holding it like a pen, resting on the chin. So how do you exactly hold it is important. How do you hold it? How do you look for it? But because these are role plays, cranial examination, I don't think you can expect actual patient in a cranial examination. They are role players, so you're not going to find any findings, but you make sure that you know how to hold these instruments. It's very important. They might give you a chart on how to read the tympanum. So hemotympanum is there, so read that, so that they can give, or else they can give findings that it's localized. What is about the positive Renes test or positive Weber's test? They can give you this findings, but as a role player, he can just mimic them, but you won't have exactly these findings won't be there. Okay, so this is something that we have to remember. Then, when you're talking about hearing also, you have to ask the patient whether he's able to hear loud sounds and the whisper test. So this is the test that we do for cochlear examination or vestibular cochlear part. Then shrugging of the shoulder, go behind the patient as you give resistance towards the patient and shrugging of the shoulder. Then for sternocleidomastoid, you have to give resistance and ask the patient to turn. And for hypoglossal nerve examination, patient can get his tongue to the cheek and you try to press it and you can protrude the tongue, ask the patient to protrude the tongue. And for gag, because we are not supposed to do a gag reflex, ask the patient to open the mouth and say ah. Okay, this is look for the vocal cord below. That's all. You should not do a test which actually causes pain to the patient. Okay, that is very important thing that we have to remember. Okay, moving on to the next part of cerebellar examination. So we'll be talking about cerebellar examination. So first in the cerebral examination is gait. Okay, gait is important. Whether the patient is walking in a broad-based gait or is losing balance while walking. Okay, then hand to toe to heel gait. Heel to toe gait is important. Next is the Romberg's test. Ask the patient to stand with his eyes closed, but make sure that you're supporting the hands here and there on both the sides. Give the confidence to the patient that I'll be supporting you if you fall, so do not worry. Romberg's test. Then you start with the eyes. Eyes, you're looking for nystagmus. As the follow the fingers, then you look for nystagmus in the eyes. Then face. What are looking in face is staccato speech. What is staccato speech is ask the patient to repeat the word British Constitution and baby hippopotamus. Okay. Then you look for the hands. There are two things in the hands. That is a overshooting scenario, and others is the pronated drift. Patient as the patient to hold it like this, it can go into pronation. It's called a pronated drift. there's one overshooting phenomenon. Don't keep it like this. The problem if you keep it like this is it's going to hit the face of the patient. So you can turn it opposite words. You give resistance. I'll be pressing it down. Don't let me do it. You hold it. Keep it hit the patient's face himself for reflexes, then coordination. What are the coordination? You can look for displayed hypokinesia or heel to toe. So these are the tests that we do for cerebellum examination. They don't give you like do cerebellum examination proper. They'll give you like the patient has a posterior cranial fossa tumor. So you're supposed to examine this patient related to that science. Okay, this we already discussed. So going on to the very important part of the examination is RS, CVS, and RS and CVS examination. So we discussed abdomen examination. Now we'll be starting about RS and CVS examination. So when we talk about CVS examination, it can be multiple things. Okay, so one thing here, it can be midline sternotomy scar, or infraclavicular scar. Okay, there can be two types of scars here. Midline sternotomy, it can patient has undergone open heart surgery or patient has a metallic heart valve. Infraclavicular, most commonly that we see in the examination, infraclavicular scar. Here, it's mostly pacemaker. Okay, these are the things that we usually see in examination. So, how do you start the examination? Again, as I told you, start with the hand examination, inspection for any tar staining is there, capillary refill, pulses, then brachial pulses. Important is pulses here. Then we look for JVP, look for eyes, face for cyanosis, eyes. Then JVP is very important. Then we go for CVS examination, proper. Here we palpate, look for the chest, any scars are there. Then we look for palpate for the heart, heave or thrill. Then we go for auscultation. So here we have to auscultate. At the end, something that we have to do is presacral edema. So we always tend to miss the presacral edema. So that we can do that we have to palpate for the apex and heaves and thrills. We look for scars. So most of the times we tend to miss the scars if it's sub infraclavicular scar. Most make sure that is covered. Auscultate all the areas, and you can do some maneuvers like forward bending or side bending to look for any accentuation of the sound. So it's very important. We have to make sure that patient is positioned in a proper way. So we have to look for GVP as a patient to turn from the opposite side and to look for JVP. So we have to make sure that we have explained the patient what you're looking for, and we have to do an auscultation in a proper way. But at the end thing that we have to remember is we have to conclude this examination by doing a proper neurovascular examination and blood pressure measurement also. Okay, so this is about CVS examination. Next is respiratory examination. It proceeds in the same way as CVS examination. RS examination proceeds the same as CVS examination. So the one thing is, again, you look for hands, look from edge of the bed before all this, then look for hands, then you look for eyes, then mouth for central cyanosis, then you look for chest proper. What are you looking in chest is shape of the chest. Okay, expansion of the chest is the expansion of normal, decrease on one side. Look for the tracheal position. If it's visible, if it's deviated towards one side, we look for the tracheal position of the chest. Okay, then we look for chest expansion. If it's normal or not normal. Okay, this is an inspection. Next, we do for palpation. We can do a handle chest expansion. Then we can go for vocal framatus. You ask the patient to keep the hand on the chest. You ask the patient to repeat 99. We can look at vocal parameters. Then we can do it with a stethoscope as well, that we can do in auscultation. Okay. Then the one thing that you have to remember in respiratory system auscultation is you have to auscultate from the front and from the back. Most of the times, if you just auscultate from the front, for example, when you're doing a serious examination, we just auscultate from the front, we don't auscultate from the back. So here you make the patient sit, you go behind. So what we most of the times we just finish the front and then we forget to do the back. So make sure you do it simultaneously. Okay, just auscultate from the front, ask the patient to bend forward, do it from the back as well. Okay, make sure you do it simultaneously. way, and just don't do it from the front, and don't forget do it from the back. Okay, most of the times it's a role player. You might have a COPD patient, but otherwise it's a role player. So auscultation, vocal parameters is done. Then yeah, so that is about the RS examination. So we have to make sure that we, in general, most important points are the general points, looking at the hand, everything. So that should not be missed. Okay. Heart murmurs. So important to know about heart murmurs, but theoretical part is only they usually ask here. Nothing. If you miss the heart murmurs, also do not worry. Okay, so that I've covered almost all the examination part. So moving on to the next thing, we'll have some questions here. We'll try to understand. And so they'll answer here, or I'll just read out the questions. Anusha, they'll answer the questions in the chat box, or I'll just read out the questions and finish it.
No, sir, later.
Okay, later. So I will just answer it. Okay, here you examine the patient with bilateral hip osteoarthritis and antalgiant with reduced internal external examination in external rotations. So here the patient, here we're talking about the patient has a bilateral. So bilateral internal external rotation. So how do you perform a Trendelenburg test? So the first thing that we have to know about Trendelenburg test is whether this patient will be able to stand on one particular limb or not for at least for 1 minute. So that is the first prerequisite. If the patient is unable to stand on that particular leg for 1 minute, then we can't do a Trendelenburg test at all. So we know the inference: if the right side of the hip is affected, left side will drop down. So we know the inference of this particular test, what exactly it does. So what does the positive mean? The whole of the fulcrum and the lever mechanism. Okay, so whole of the fulcrum and the lever mechanism is affected. Okay. That's a positive movement. What movement is lost first in the hip? So usually, what are the movements that rotations? So so how do you tend to ask the patient to stand on the affected leg? If the opposite side sound tilts positive, it's weak abductory mechanism is weak. So then moving on to the rotation. So which is the first movement that is lost in the any arthritis of the joint? Usually rotations. In rotations, the very common joint that is affected is the hip joint. Okay. So internal rotation, hip joint. Okay, a patient was referred for incisional hernia. In the midline examination, you find a midline bulge on straining and a wide gap between the recti. So here they're talking about incisional hernia. Do you agree with the GP now? So do you agree that this patient has an incisional hernia? Okay, a true incisional hernia, what happens in true incisional hernia is there's a facial defect. Okay, there's a incisional hernia has a facial defect plus a divertication of recti. So that is a classical finding of an incisional hernia. Then divertication has no true or false deficit. So there's a risk of triangulation. Usually here the risk of triangulation is decreased compared to other areas. Then how do you confirm? So what are the important tests that we do to confirm is, one, you can get an ultrasound done, or you can get a CT scan also to understand where exactly the hernia is. So how do you manage this? And in incisional hernia usually it's managed conservatively unless this patient has pain or presents later with a pain where it needs a surgery. Otherwise, till then it's not required. Moving on to the next question. What is a midline sternotomy scar and an audible metallic click, and is listed for the elective hernia repair? So what is the importance of this click? So here we're talking about metallic heart sound. It's a replacement, it's a heart valve replacement. That is not the problem here. The problem is the patient has undergone an midline sternotomy scar and an open heart surgery. There's high chances this patient is on blood thinners. So when this patient is already on blood thinners, there's high chances. So we have to make sure that this patient is, what kind of blood thinners is taking, if it's taking warfarin, or so it has to be stopped prior to the surgery and converted to low molecular heparin. So this is the precaution that we have to take. So we have to understand why this metallic heart valve is there. So how do you prepare? So we have to make sure we have got the blood reports done, the INR, what is the level of the INR, proper prophylaxis. Patient has to be explained why are we stopping the blood thinners, why are we giving the other blood thinners. So that is one thing. Stop warfarin, bridge with lomoglutaparin. So that is an important protocol that we follow for before any surgery. Then once after the surgery is done, you can start the patient back on lomoglutaparin. Then again warfarin, and you can stop lomoglutaparin as the warfarin takes effect. So depending on whatever the medications he's taking. So we have to make sure that it's bridged in a proper way. So a young woman has a 9 month history of back pain now with urinary incontinence and dermatomal loss. So here, as I told you, in a spine, what is the most important red flag sign is a cauda equina syndrome. A lower part of the spine where a cauda equina syndrome affects the nerve roots that's applying to the bladder and the bowel is very emergency. This patient might need a immediate surgery. Then what is the bedside test? So we have to make sure we do a parectal examination to understand if there is any tone loss, and we have to look for saddle sensation. If the saddle sensation is there or not. So what are the investigations and how do you manage? The most important sign for any cauda equina syndrome is this. There is a loss of bladder and bowel continence is where the problem starts. So what is the first investigation that we do is we get a MRI. So understand, yeah, this is a cauda equina syndrome, and the management usually involves is definitive management is immediate surgical decompression. The more we wait, the lesser the chances of recovery. So it's very important that we do an emergency surgical decompression. Okay. So here the question on the cranial nerve examination, the patient has loss of outer halves of the both the visual fields. So what is the field defect when there is loss of both outer aspect of the visual field? That is called bitemporal hemianopia. Where is the lesion? The lesion is at the level of optic chiasma. What is the commonest cause for this lesion at the level of optic chiasma? It's because of pituitary gland. So when the pituitary gland compresses on the optic chiasma, it has high chances of bitemporal hemianopia. So, what are the things that we have to make sure to understand? This is because of the pituitary gland. So, we have to ask for the symptoms of acromegaly or any other endocrine features the patient has, something related to thyroid. The patient has the face of the patient, or the patient of the patient. So, we have to understand where exactly it is coming from. So, we can get an MRI plan and to understand why the visual field defect is present in this patient. Then moving on to the next question. The patient has swelling in the groin extending into scrotum. You cannot palpate above the swelling and there is a cough impulse. So this is a very important thing that we have to know how to differentiate between hydrocele and hernia. As I told you before, in hydrocele and hernia depends on what kind of hydrocele is it. For example, you do a pediatric age group when there is a patent process vaginalis. In there, the only differentiating factor between a hernia and hydrocele is transillumination. Because of patent process vaginalis, we will not be able to get over the swelling in that hydrocele. But when you see a hydrocele in an adult age group, you will be able to get over the swelling in a hydrocele, and transillumination is positive. But you can't, transillumination is negative in a hernia, and you can't get over the swelling in case of a inguinal hernia. So that is very important. So what is the next step? First we have to understand, is this hydrocele or a hernia? We have to look whether it's reducible or non-reducible. Then we have to examine the contralateral side also. Then we have to get further investigation done. Then we can plan for the surgery. That is the role of management. Okay, so that basically gets us to the end of the session. So we have few other things that we have to cover here. Like as I told you, I've already explained this, but here we have put it in a chart form. Start examining before washing your hands. So very important is wash your hands. Do not hurt the patient. Be respectful. Have empathy. Okay, so compress the leg for ABPI, miss the parectal examination. You have to tell, you can't do a parectal exam, but you have to tell that I have to do a parectal examination. So thyroid status, we have to make sure you have to examine the hand. Examination is silence, you're going to lose the marks. Okay, always open with wipe protocol. Talk to the patient, explain to the patient. Introduction is important. Offer to finish the relevant system. So you're not able to finish it, you have to make sure that you include it in the end. That I want to finish the examination by doing a neurophysical examination. Examine the opposite limb, everything. So give a structured summary where only positive points are given. Not just keep on bombarding with excessive knowledge. It's the patient examiner is not going to take it. So give whatever is required. It's not like you talk too much, you take a lot of time, then that's not going to happen like that. Okay. So one important thing here is I would like to complete by doing this. So that is one thing that we have to do. Most of the time in spine examination, we might not be able to complete the whole of the examination. That time we have to make sure we tell that I have to complete the examination by doing this particular examination, like rectal examination for abdomen examination, neurological examination for spine or limb examination. So that is also important thing that we have to. Good. Okay. So different spot diagnosis that we encounter is one thing that I want to give. Yeah. So top Viva pulse is this one. So lump. So when you see a lump in the neck, so a lump that is moving with the tongue protrusion is thyroglossal cyst. Lump that we moves with the deglutition is thyroid. And when you're unable to get over the swelling is inguinal scrotal hernia. So positive slip sign and no translumination. So this is the swelling which has a positive slip sign. What is a positive slip sign is? It's a lipoma. Then opposite pelvis dropping down is Trendelenburg test. Most sensitive test for ACL when you give both the options like Latchman's and anterior. Latchman's is more sensitive compared to anterior. Dilated tortuous superficial leg veins is because of varicose veins. It can be cephalofemoral junction incompetence or it can be a perforator incompetence. Then moving on to the next minute. This is already done. Okay, so when there is a loss of outer, so we have discussed this outer half of both the visual fields. It's called bitemporal hemianopia. Hemitympanum after the surgery, when there's a base of skull fracture, tenar wasting, there is carpal tunnel syndrome. Audible metallic click, it's a mechanical prosthetic valve. Backsaddle anesthesia because of cauda equina syndrome. Stoma is not a part of MRCS, so do not worry about that. So claudication, claudication examination, we have to make sure what claudication exactly they're talking about. Whether the claudication is because of the neurological claudication or vascular claudication. It's because of the spine or it's because of the vascularity. So that is we have to discuss when you're doing examination. We have to try to find out. We're talking about a backache. So it depends on what kind of claudication it is. Then thigh and buttock claudication, where is the block? Usually it's Leary syndrome, iliac block. Post-op midline incision, GP says incisional hernia. So this is all everything that what we have discussed. Okay, then CVS examination, midline sternotomy scar. So midline sternotomy scar, it's a prosthetic valve pacemaker. If it's a subclavicular scar, then it is a pacemaker. Okay. The next is Trendelenburg gate, we explained knee examination, ligament test. So everything that is written here, we have already discussed. So these are some things that keep on coming in the examination part. Okay. So neck thyroid examination, submandibular gland, lump in the back, cranial nerve examination, head injury. So this is all what we discussed in the classes before this. Everything is a recall that we have spoken today. So this is because Part B recalls are not that common. They can ask news stations, but we have not encountered news stations. The recent news station that has come is counseling before the surgery. Like it's a PAC, pre-anesthetic checkup, where we do. So that is one thing. So these are some of the things that we have taken. And yeah. Okay. So anyone think so done the Nanisha? That's it. Wait for anything.